the organ involvement in systemic lupus erythematosus. The word systemic means multi-system involvement. The word lupus means wolf-like faces. The word erythematosus means reddish lesions. Just a brief note about the systemic lupus erythematosus. It is an autoimmune disease affecting various organs and cells and undergo damage by tissue-binding autoantibodies and immune complexes. It has a varied protein manifestation ranging from mild disease to severe life-threatening organ complications. The pediatric onset for systemic lupus erythematosus will be less than or equal to 16 years of duration, whereas the late onset SLE would be more than 50 years duration, which has increased frequency of involvement of serosa and pulmonary involvement and renal involvement. Most antibodies characteristic of each person are present at the time of clinical manifestations. Coming to the frequencies of various manifestation. Constitutional symptoms like fatigue, fever, weight loss will account for 90 to 95%. Mucocutaneous involvement and musculoskeletal involvement both account for 90%. Serositis, glomerulonephritis was around almost 50%, and the last neuropsychiatric manifestation of 40%, and the least would be hematological manifestations of around 20 to 30%. Various books gives a slightly varying number of frequencies, but still this would be an appropriate table. Coming back to the musculoskeletal involvement in systemic lupus erythematosus. Systemic lupus erythematosus has a wide range of musculoskeletal involvement ranging from arthralgia to arthritis, involving wrist, elbow, shoulder, hand, and even foot and knee joint. If at all an SLE manifests like an erosive disease like rheumatoid arthritis, where rheumatoid arthritis have subcutaneous nodules and a joint deformities, then this manifestation SLE plus rheumatoid arthritis is called as lupus. Note that only 5% of SLE joint disease or 5% of SLE musculoskeletal involvement like arthritis, arthralgia would go for an erosive disease. Same way, if you find a single joint pain or single joint tenderness with a prolonged steroid use, and that seems to be most likely a major joint like shoulder or hip, then that is called as ischemic necrosis of bone or avascular necrosis, which is easily detected by MRI less than 24 hours or can be X-ray in a week or so. SLEs are also prone to cause myalgias and without frank myositis. SLE causing myalgia or a myositis should be differentiated from hydroxychloroquine is causing a weakness and steroid-induced myositis or myopathy, where in case of a later, you have a normal CK total and muscle biopsy will not show any inflammatory changes. Whereas in case of a myositis caused by SLE, there will be inflammatory changes and raised CK-MB and CK total. Moving on to the next involvement, cutaneous involvement, which is broadly called as lupus dermatitis, which involves acute, subacute and chronic skin dermatological manifestations, which was classified and given by Gilliam. The most common manifestation would be acute cutaneous lupus erythematosus, which can be of localized or generalized, and subacute can be of annular and papillosquamous, and chronic cutaneous lupus erythematosus, which is most commonly DLE. What the DLE stands for, discoid lupus erythematosus. Just moving on to a few images to explain. It's one of the patient which we encountered who had a typical pattern of a malar rash, which is a most common pattern sparing the nasal bridge usually. Sometimes it may also involve nasal bridge. This is called butterfly rash and malar rash, which is the most common manifestation of an SLE. And you can also find some discoid lesion, some chronic lesion, annular lesion over the mouth with a central clearance and with a rash of very potent manifestations. This is an example of a patient with a malar rash and a discoid lupus erythematosus. Remember a fact that a 5% of SLE would go for a DLE. Again, coming to one more image of a patient where you can find a central cleared area and a peripheral hyperpigmented area. If you find here, there could be some furs, some small fur will be there. It can also occur at this point of this site. It can also occur at any site, and this is something called as carpet tack sign, or also called as tin tack sign, or also called as cat tongue sign. Where there will be peripheral erythematous region with the central clearance and small fur-like things will be there. There is one another manifestation which we study in chronic cutaneous lupus erythematosus, also called as classic discoid lupus erythematosus, under which we have studied something called as lupus paniculatus or profundus, where there is a subcutaneous involvement of lupus erythematosus, which will be erythematous red diffuse lesion kind of thing, which is called as lupus profundus. Okay, for completion's sake, small ulcers present over the oral mucosa, like after salicylic presentation, may or may not be painful, can also be present in systemic lupus erythematosus and cutaneous manifestations. Given overview of treatment can be topical or injectable glucocorticoids with an antimalarials. The third manifestation will be nervous system manifestations. It can be central nervous system and peripheral nervous system manifestation. The most of the pathological process involving it would be a thromboembolic event, or it can be small vessel vasculopathy, or it can be atheroembolic disease process. If the organ manifestation in SLE is a diffuse process, for example, a diffuse nervous process, it requires an immunosuppression, whereas if it's a vascular-occlusive process, it only requires an anticoagulation. Here is one another table which shows the neuropsychiatric manifestation in systemic lupus erythematosus. The most common would be cognitive dysfunction. Following that, it can be a psychosis, mood disorder, acute confusional state, anxiety, myelopathy. All these are central nervous system manifestation. Coming to the peripheral nervous system manifestation, it can range from just a mononeuropathy and a polyneuropathy to a myelopathy to a Guillain-Barré syndrome and autonomic disorders and multiple things. So, I want you to be very clear that the most common disease manifestation given in most of the textbooks will be cognitive dysfunction, psychosis, mood disorder. 2. Ranging and headache, ranging from central nervous system, and a peripheral nervous system can be a monopathy or a mononeuritis multiplex, or it can be polyneuropathy, plexopathy, or even Guillain-Barré syndrome. If at all you encounter a central nervous system complication like seizures, the most likely treatment would be an anti-epileptic drug with an immunosuppression. The headache associated with SLE will be progressive headache, and it indicates a flare-up reaction. Psychosis is the most dominant manifestation in SLE, and to distinguish from other glucocorticoid-induced psychosis, we have certain clinical parameters. When you give a patient of a dosage of more than or equal to 40 mg of glucocorticoids, or patient having a psychotic behavior or a mood disturbance within 1 week of starting of therapy, then it would be most likely a glucocorticoid induced psychosis rather than a psychosis associated with SLE or NP-SLE, and the patient responds to dose reduction. Myelopathy. Again, myelopathy is one of the serious complications of SLE. It responds to high dose glucocorticoid therapy. Coming to the vascular and cardiovascular manifestations in SLE. It ranges from pericarditis with or without effusion, which is the most common manifestation. Myocarditis is rare, although a serious complication, and it should be distinguished from hydroxychloroquine toxicity. So, a baseline ECG is required for a patient of SLE to distinguish from whether they have gone into a HCQ toxicity induced myocarditis or it is a myocarditis associated with SLE. Significantly, an endomyocardial biopsy would show an inflammatory changes in case of a SLE associated myocarditis, whereas in case of a HCQ related toxicity, it will just show myocardial vacuoles, no inflammatory changes. When we talk of endocarditis and valvular lesions, it is the most serious, most life-threatening complications, which also has a valvular lesion, can also have valvular lesion. The valvular lesion, when it is a fibrinous deposits forming a plaque which over the under surface of the cusp and the valve, under surface of the valves, if you find, these are something called as Liebman-Sack endocarditis. Mostly left-sided lesions are common. Mostly they have mild symptoms. Mostly they have regurgitant lesions because they are present under the surface of the valve and they are not present over the surface of the valve or between the valves. When you find someone with having a Liebman-Sack endocarditis or any cardiac manifestations, it is better to do an anti-cardiolipin antibody and an anti-lupus anticoagulant antibody because there is a increased association between cardiolipin antibody, lupus anticoagulant antibody with the SL endocarditis. Not to forget that coronary artery disease, most often caused by accelerated atherosclerosis, can cause intramural or extramural thrombosis. Young women less than 40 years or a smoker, diabetic, hypertension have 10 to 50-fold increased risk of myocardial infarction, whether the disease is active or inactive. Antiphospholipid antibody again has increased risk of coronary arterial thrombosis, approximately 50%. Just to note that the prevalence of transient ischemic attacks, strokes, myocardial infarction is increased in patients with SLE. These vascular events are increased in but not exclusive to SLE patients with antibodies to phospholipids, which are associated with hypercoagulability and acute thrombotic events. Vasculitis with a bland vascular occlusion requires anticoagulation plus an immunosuppression therapy, whereas a pericarditis just requires an NSAIDs and failure to respond to NSAIDs may require further evaluation into other cause of endocarditis and myocardial involvement. Coming to the pulmonary manifestation in SLE, the most common pulmonary manifestation would be pleuritis with or without pleural effusion. The most dreaded complication would be an pulmonary fibrosis or intra-alveolar hemorrhage in the form of diffuse alveolar hemorrhage would be life-threatening complication. Whereas the pulmonary infiltrates, if you find, it would be an active disease of versus infection. One has to differentiate, a clinician has to differentiate whether it is an active disease or an infection. Less than 5% of the patient would go in for pulmonary artery hypertension, and it is almost always same like idiopathic pulmonary artery hypertension. Down you find an image of a chest X-ray of a 40-year-old male who suddenly came to hospital with a severe respiratory distress and hypotension. And the X-ray image shows bilateral infiltrates, homogeneous infiltrates, dispersed diffuse homogeneous infiltrates present. Most likely it would be a diffuse alveolar hemorrhage, and it is a serious life-threatening complication. So just a brief view about how do you treat. So pleuritis just involves an NSAID, and diffuse alveolar hemorrhage or interstitial pulmonary fibrosis requires immunosuppression, whereas effusion needs some analysis for infection, whereas infection, if you prove it, needs some antibiotics. Coming to the hematological manifestation in SLE, the most common hematological manifestation would be homocytic normochromic anemia. Leukopenia, especially lymphopenia, which is preponderant to some infection, would also be seen in SLE. Thrombocytopenia may be recurring a problem. High dose glucocorticoid therapy is required for early episodes of hemolysis or severe thrombocytopenia, and there is a good response when it is used in the acute phase. Coming to the gastrointestinal manifestations in systemic lupus erythematosus, most mild disease would like to cause nausea, vomit, sting, to abdominal pain can be tolerated, to a pain causing rebound tenderness, and can also cause cardiac rigidity, in which you have to suspect autoimmune peritonitis or intestinal vasculitis. Note, there can be an increase in serum AST, ALT levels, which also indicates the disease is active. But once a glucocorticoid therapy is started, these patients may respond in the form of decreased trend in AST and ALT. Vasculitis involving gastrointestinal tract is a life-threatening complication starting from bleeding, perforation, or even sometimes mesenteric ischemia or we say as ischemic colitis. Going on to the next important manifestation in SLE, which is called renal system involvement. Nephritis is the most serious manifestation in case of SLE. Most people are asymptomatic at early stage. 90% of the SLE have a pathological lesion on biopsy. That's why urine analysis is indicated for all patients with SLE. Coming to the point where renal biopsy can be done or not, when clinical evidence of nephritis like proteinuria or hematuria is there, then the patient should undergo a renal biopsy, because renal biopsy at an early stage with the proper clinical evidence would give us to start an early onset immunosuppressive therapy that will prevent a glomerulonephritis like a TPGN going in for an end stage renal disease. So coming on the statistic, 10% of the diffuse proliferative glomerulonephritis will go into end stage renal disease or sometimes even die if untreated for a duration of 10 years. That's why lupus nephritis gains an importance at an earlier detection might prevent a fatal life-threatening organ complication. A separate group called International Society of Nephrology and Renal Pathological Studies have given an histopathological classification for lupus nephritis under 6 stages, which I will be discussing in lupus nephritis topic. The treatment would be a glucocorticoid therapy with an immunosuppression would almost always prevent further renal damage and increases the life expectancy in a patient of SLE nephritis. Ocular manifestation. A generalized Zika symptom can be there, or can be non-specific conjunctivitis or a retinal vasculitis or optic neuritis, which is always severe and again life-threatening complication in forms of vision-threatening, we can say. Aggressive immunosuppression is required with steroids, steroids in this case. Just to see how can retinal vasculitis can present. It can just present with multiple dot and blot hemorrhages to a complete occlusion causing a pale fundus. A multiple dot and blot hemorrhages in case of a blot hemorrhages in case of an active disease to a pale fundus in case of an occlusion. Okay, coming to the overview finally. Just coming to the overview, just we will revise the clinical manifestation of SLE and the prevalence over the entire course of disease. The first would be a constitutional symptoms like fatigue, fever, malaise, anorexia and weight loss for 95%. Coming to the organ proper, it could be musculoskeletal involvement and arthralgia and myalgia accounts for 95%, and others like non-erosive arthritis, hand deformities, myopathy, myositis and ischemic necrosis of bone or AVN, which accounts 15%. Again, coming to the cutaneous manifestation, which is the next common manifestation in SLE, would be photosensitive rash like malar rash, which accounts for 70%, aural ulcers, alopecia, discoid rash of chronic dermatological manifestation of SLE, vasculitic rash, urticaria, subacute cutaneous lupus, lupus profundus, 50%. Coming to the next manifestation called hematological manifestation, anemia of chronic disease can be of 70% manifestation, leukopenia in less than 4,000, the criteria is less than 4,000, 65%, and lymphopenia less than 1500 per microliter of blood, it can 50%, and thrombocytopenia of less than 1 lakh of 15%, and other can be lymphadenopathy, splenomegaly and hemolytic anemia. If it is hemolytic anemia, the patient might request a trial of steroid pulse therapy, because that will benefit at an earlier stage. Coming to the fourth important organ system involvement, it could be a neurological manifestation, wherein which you can cognitive dysfunction, as I said, mood, depression, headache, seizures, monotopolyneuropathy, stroke, transient ischemic attack, confusional state, movement disorder, aseptic meningitis and myelopathy, which is always very rare. Fine. Coming to the cardiopulmonary, which we have already seen, would be pleurisy, pleural pericarditis, if with the diffusion, myocarditis, endocarditis, which is again a life-threatening one, which is also called as Libman-Sack endocarditis. Again, lupus pneumonitis should be distinguished from infection, coronary artery disease. Again, APLA to be done for this patient and increased risk of thrombosis. interstitial fibrosis, life-threatening complication, pulmonary hypertension, ARDS, hemorrhage called as diffuse alveolar hemorrhage, and shrinking lung syndrome, which is a progressive restrictive lung disease causing elevation of diaphragm because of diaphragmatic weakness, causing decreasing lung volume, which is less than 5%. Again, when you talk of the renal involvement in SLE, good proteinuria, cellular cast, or you have a nephritic picture, definitely renal biopsy is indicated. Can some person turn out to be nephrotic syndrome also, and if untreated can go for ESRD. Gastrointestinal manifestations are nausea, mild pain, diarrhea too, abnormal liver enzymes too, vasculitis in terms of ischemic colitis, or they can also go in for mesenteric ischemia, also going for other vasculitic manifestation in the abdomen. Thrombosis or vascular complication can be of more of venous more than arterial. Ocular, sicca, non-specific conjunctivitis, episcleritis or vasculitis. In vasculitis it is called retinal vasculitis, which is again a vision threatening or endangering problem. It's only 5%. So this is just an overview of what are all the organ system involvement, starting from musculoskeletal, cutaneous, hematological, neurological, cardiopulmonary, renal, gastrointestinal and ocular. For the completion's sake, to know about the new ACR Euler criteria for classification of SLE, all patients classified as having systemic lupus erythematosus must have serum ANA of more than or equal to 1:80 plus at least 10 points from the clinical domains or immunological domains. Okay, both clinical plus immunological domain combined together, you have to at least have 10 points. Remember to note this, when a patient is positive for one criterion, need not overlap with the time when the patient is positive for other criteria. This is one point. Secondly, if a patient is positive for more than one criterion in a domain, only one criterion with the highest point value accounts. So, for example, if a patient is having an acute cutaneous lupus, it gives a score of 6. So, even if a patient having oral ulcer, you should not take the 2. You should always count as 6. Similarly, if you take a renal domain, so if you take a hematological domain, if a patient is having an autoimmune hemolysis, that counts for 4 points. So, if the patient is having leukopenia, you should not add 3 more points. So, which comes to a conclusion that each clinical domain, you should always consider the manifestation giving the highest score to be considered, even though there is one more manifestation with the lowest score. So, just briefing on the domains, same way: constitutional domain, cutaneous domain, arthritis domain, neurological domain, serositis, hematological, renal, and immunological domains like antiphospholipid antibody domain, complement protein domain, high specific antibodies domain. Remember to note that this is not the absolute diagnostic criteria, and to emphasize, this is only a classification criteria for SLE. Down, you could see an image of a patient, around 35-year female, who came with cutaneous manifestation, plus she also had hematological manifestation in terms of lymphopenia, leukopenia and thrombocytopenia, plus on biopsy, on urine analysis, she also had more than 1 gram proteinuria and minimal cast percent. So this patient, biopsy was done, and biopsy was showing class 3, class 5 lupus nephritis, and she had DLE lesions, she had ACLE lesions, she had photosensitive rashes, and this is on a follow-up after giving a pulse drug and starting methylprednisolone prednisolone dose of 1 mg per kg body weight, and now we can see really her lesions have improved, and she came with a lesion in the first image. She had bilateral severe malar rash, bilateral lesions, discoid lesion, ACLE lesions over the photosensitive areas. Now she is recovering. This is one of my case which I have seen a couple of weeks earlier. Thank you so much for listening.